Welcome to today's post-COVID-19 condition webinar. The presentations will be delivered in English, but French captions will be posted with the recording afterwards. As we gather today, we acknowledge that we are on Treaty 2, 4, 5, 6, 8, and 10 territories and the homeland Métis. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We pay our respect to the First Nation and Métis ancestors of this place and reaffirm our relationship with one another. To start, we have two quick polls to learn more about who is in the audience and with your familiarity with today's topic. The first poll should be appearing on your screen now. Please select your role from the list. We're excited to have two wonderful occupational therapists as our speakers today. And our allied health are about a quarter of our individuals here today. Patients with post-COVID condition are another quarter. And we also have physicians, pharmacists, policymakers, researchers, and public and family members as well. So everyone is welcome. I'll move to the second poll now. And the second poll should appear on your screen, and we're looking for your current knowledge levels. So far across the topics, the knowledge level is predominantly low. We have a range of knowledge level as well, but it's predominantly low. This session is accredited, and you will receive a certificate after the session. And you'll also receive an evaluation form. The link will be in the chat at the end of today's session, and the recordings will be available after the series. Please post questions in the anonymous Q&A function with your name visible in the chat. During the Q&A section at the end, you'll be able to raise your hand and also unmute. These are the steps we have taken to mitigate potential sources of bias. And we're excited to have today two speakers. Lindsay Roysum is an occupational therapist at Stapleford Health and Rehab Center in Regina and a concussion rehab specialist. Lindsay has been practicing OT for 18 years and certified in cognitive behavior therapy for insomnia, has a special interest in autonomic nervous system regulation, and a focus on creating healthy habits and routines that support people's goals. Melissa Croskery is an occupational therapist at Continuum North, working throughout the Northern Territories, and has been practicing OT for 14 years, with expertise in general pediatrics, child and youth mental health, trauma-informed practice, and self-regulation. Melissa has lived experience with long COVID, including brain fog, and is a member of the CAN-PCC National Collaborative and co-chair of the neurological and psychiatric topic. On to you, Lindsay. Thank you.
Thank you for the introduction, Carolyn. So today go to the learning objectives. Thank you. So today our goal is that the people attending here will be able to describe brain fog, its relation to the post-COVID-19 condition, understand the lived experiences of those suffering from brain fog, describe management of brain fog, understand some treatment options for people who have PCC and brain fog, and understand the CAN-PCC recommendations for PCC and how it relates to brain fog. So we'll go to the next slide. So what is brain fog? Brain fog is not a medical term, but rather a common term used to describe a number of cognitive symptoms, including difficulties with memory, word finding, feeling sluggish mentally, poor attention, and concentration. This term has been around for a while, the term brain fog, and prior to the COVID-19 pandemic, but after the pandemic, it became a very popular term. Brain fog has been known to follow viruses, concussions, and surgeries. It also can be associated with anxiety, depression, insomnia, and high levels of stress. It is also present in other chronic conditions, including myalgic encephalomyelitis and chronic fatigue syndrome. So it's not, it is a symptom of post-COVID-19 condition, but it's not required to have that symptom for a diagnosis.
Yeah, so in terms of the prevalence of brain fog and PCC, as of June 2023, the Government of Canada released a report indicating that 3.5 million Canadians have experienced longer-term symptoms following a COVID-19 infection, and almost half of those have experienced symptoms for a year or longer. I did actually find one prevalence statistic about brain fog, and I apologize, I didn't update the slide, that indicated that about 13% of people with post-COVID condition also experience brain fog. My own feeling about it is that it's likely higher than that, but it is definitely one of the common symptoms of long COVID. Considering that also that the majority of people experiencing post-COVID condition are in their 30s, 40s, 50s, this can obviously have a really significant impact on their daily functioning, particularly when it comes to their ability to work. Next slide.
So executive dysfunction, I'm just going to talk a little bit about, because executive functioning skills are complex, higher level cognitive processes that help us execute tasks. These are our brain skills that actually help us do things. They include things like sustained attention, planning, organization, time management, working memory, prioritization, that like higher level organization. There's not one area in our brain that controls these skills, but rather a number of different areas in your brain work together just to help us execute daily tasks. So executive dysfunction would be more the technical terminology for brain fog. We find that as people describe a cloudiness in their thinking, it really impairs these executive functioning skills. People describe this difficulty with concentration, remembering what they're doing, even while they're doing a task, difficulty multitasking, or breaking an activity down into the steps required, often feeling like they don't even know where to start. So that's kind of the picture of brain fog, which also could be called executive dysfunction.
Yeah, so I thought I'd just take a few minutes to explain my own lived experience with COVID or post-COVID conditions. So I've had, unfortunately, multiple infections, and the first infection at the time, I didn't realize it was COVID. We sort of figured it out later, but it was very early on in the pandemic in February of 2020. I'd done some travel for my son who had some medical issues, and we got really sick. And then I just wasn't getting better. I started having what just felt like something systemic happening, and I was going to doctors and specialists and getting all the tests. And my symptoms continued just to get worse. So I had to go on puffers because had breathlessness all the time for no apparent reason. And then the fatigue was really intense. Probably the worst symptom for me, honestly, was the brain fog. It got to a point where I really couldn't work. I had no memory. I couldn't find my words. I couldn't focus on anything. And so that lasted about 2 years. In April of 2022, I, again on travel, got COVID again. And an interesting thing that happened for me was when I recovered from that second infection, a lot of my symptoms improved, which was very welcome, obviously. So the fatigue and the brain fog symptoms definitely improved quite a bit. Unfortunately, I got COVID again in December of 2022. That episode led to me having what I would say are now consistent, more like sinus issues. I've had chronic sinus infections, also rashes and like allergic symptoms to things. In December of 2023, I got a booster. It was my fourth one, and I'd reacted a little bit to all of the vaccines. But this one caused a really big crash for me. And so I had about 6 weeks of really intense fatigue and brain fog after that, and then slowly improved from there. And then unfortunately, I got COVID again in June of 2024. And since that one, I've now developed POTS. So issues with blood pressure and dizziness and all kinds of other things. So, and I promise I do all that I can to try and avoid COVID. I know there's been some recent, I think, evidence that potentially people who have long COVID, seem to be more susceptible to catching COVID. So I assume that's maybe what's happening with me. So if you go to the next slide. Yeah, so just in terms of my brain fog, I did mention like when it was really bad, I had really poor memory. I really couldn't concentrate on anything. My word finding was horrible. Like sometimes I just couldn't even put a sentence together. Really poor problem solving, and reading and writing became nearly impossible. When it's at its best, and my symptoms sort of come and go. Obviously, if I'm sick or really stressed, they get worse. I still have mild word finding difficulties. You might hear it during this presentation, especially when I'm tired. So usually in the evenings, it's worse. Sustained attention can be really difficult. For me, it's really when I'm reading or writing. So I'm almost at a point where I listen to audiobooks exclusively because reading has become really challenging. And writing for me, it's a lot of it is the initiation, and then being able to stay focused on the task is also really difficulty. And sometimes I still have some issues with memory and some planning issues. One thing that I notice is that I used to remember both faces and names of anyone I met. Like I never had issues with that. And now that's become really difficult for me. I need to write it down or, have some kind of visual to remind myself of that for work. So yeah, so that's just a bit of my own experience.
So yeah, we're going to come back to me now. So assessing brain fog. So our general neurocognitive exams that screen for mild cognitive impairment, the mini mental exam, the Montreal Cognitive Assessment, or the MOCA, they're not generally going to pick up the symptoms associated with brain fog. And these might be the typical tests that they're quick, they're this quick screen. Every med student gets taught how to do them. A lot of professions do them. So they might use those when if people are explaining that my brain doesn't feel right. These aren't going to be sensitive to this type of impairment. And so that's why that was one of the reasons that I mentioned executive dysfunction, because if we look more into executive functioning assessments, that's where we're going to actually pick up on these deficits. So we can actually help tease out the symptoms, but also more importantly, come out with what's impaired so that we can make a treatment plan and strategies. In my practice, I use the test of everyday attention and the weekly calendar planning activity to help determine specific areas of deficit so I can help formulate those treatment plans. These are both activity-based assessments. They have normative data and they have high ceiling effects. So it makes it easier to pick up the deficits people are reporting. So whereas like the MOCA and the mini mental really are looking to pick up those early signs of dementia, right? So these are really function-based. They look at these sustained attention, working memory, how you organize, how you plan, how you filter out distractions, all of those things. So these are longer assessments, but they do pick up on the deficits people are speaking of, and actually often just help validate people saying, things don't feel right, I'm not thinking right. And then we do the assessment and they're like, I'm glad this shows the problem that I've been having. So that's kind of what I do for assessment of brain fog, is I look at those function-based ones.
Before we get into some of the CAN-PCC recommendations, I'll just review what the implications are for strong and conditional recommendations. So when we're looking at this, we're looking at patients, healthcare professionals, and for policymakers. So a strong recommendation for patients is going to mean that people will want to follow it, and there might be a small proportion who would not. A strong recommendation for healthcare professionals means that they'll want to prescribe it. Adherence could also be used as a quality criterion or performance indicator, and decision aids are not likely to be needed. And for policymakers, again, a strong recommendation, they'll want to adopt it in most situations as a performance indicator. When we have a conditional recommendation for patients, most people will want to follow it, but many might not. And most people will want to discuss it with a health professional first. For healthcare professionals, a conditional recommendation will mean that they'll want to prescribe it, recognizing that different choices will be appropriate for different patients. Decision aids might actually be useful to help people make a decision that's consistent with their values and preferences. And for policymakers, when it comes to conditional recommendation, policymaking will require substantial debate, and policies are more likely to vary. Performance indicators would measure adequate informing and discussion. Next slide. So for our first CAN-PCC recommendation, we were looking at cognitive screening. And so the recommendation that we made is that the CAN-PCC Collaborative suggests against cognitive screening tests in adults with suspected or confirmed post-COVID-19 condition. And so this was a conditional recommendation based on very low certainty in the evidence. And so the reason that we came to this decision, there's multiple reasons really, but it's what Lindsay's already mentioned, is that for those presenting with cognitive symptoms with PCC, they're going to need a detailed clinical evaluation, right? So the available screening tests that are most commonly used are just not suitable as a screening tool for this population because of the more subtle cognitive deficits that we often see, as Lindsay mentioned, that present like brain fog or executive dysfunction.
So when I look at if someone comes to my practice and they are telling me that they have brain fog, and and definitely I will assess that more detailed assessment like we talked about. But then when I'm trying to start shifting into treatment, my very first steps are my clients' basic needs being met? So what I consider our basic needs for wellness, what's their nutrition, their water, their exercise, their sleep, their rest. So a lot of our PCC clients are barely getting by due to fatigue, a feeling of being overwhelmed, and stress around their symptoms. And as well as just this thought of not being validated, maybe a loss of income, unable to complete their daily activities. So we really need to examine these areas first, as they're really vital to healing. When we look at all the potential causes of brain fog, we want to ensure that we're not confounding the impact of post-COVID condition by not having their basic needs met. So we can go to our next slide. So I'll get people to reflect, am I nourishing my brain and my body? So ideally, we want to look at an anti-inflammatory diet. Harvard Health has some nice patient resources that kind of talk about foods that fight inflammation. But there's research across pain journals, concussion research, ADHD research, chronic disease research, and dementia journals on utilizing an anti-inflammatory diet to help with our cognitive functioning. We really need to start small and build success, help people meal prep and plan, see if they have someone who can help support them in this. For example, could someone do a grocery run for them? Could they get groceries delivered? Could they pre-cook a bunch of chicken breasts in the oven for the week, for example? Things like that, just to help build that success in. I do say to involve a nutritionist, but I want to make sure that we realize that a nutritionist might overwhelm them if they aren't familiar with people who have chronic fatigue and chronic disease management. So they might need an occupational therapist to work along with the nutritionist to break those tasks down and help make a plan with the goal of healthy eating into smaller, manageable steps. Also, just note that digestion can be a trigger for post-exertional malaise, and some of these foods might be harder to digest. So we have to individually tailor these plans just to really, how am I getting my nutrition and not causing myself to then crash because I'm eating all these healthy foods. Am I hydrated? So I just pulled a quick stat. Harvard Health suggests women should be drinking around 11.5 cups of water a day. This is going to vary for activity level and general needs. And I should have put a men's statistic in there as well. I apologize that I didn't. Most of my clients that I have on my caseload are women, but I know that there's men out there suffering as well, and I did not put a stat for that, but we can look that up for sure. Just note that hydration is key for our entire body to function, and dehydration, chronic dehydration, can cause brain fog, right? This is one of the causes of brain fog. So once again, we just don't want to confound all these factors. So reminders on watch, trackers, pre-filling our water for the day, setting the intention. Those are all strategies for just helping get that water intake. But sometimes it's that question, am I getting enough water, and really paying some attention around it. So exercise is very important for improving our cognitive functioning. The actual amount recommended for cognitive health, it really varies across studies, but with the diverse symptoms of PCC, we need to ensure that our clients are exercising enough to get their heart rate elevated. This may need to be supervised by an exercise therapist at first, and the program will likely have to be tailored to the individual's needs. Even getting outside for a walk can be vital to physical, mental, and cognitive health. It's important to note that some people with PCC also may experience post-exertional malaise, causing them to crash after exertion, including physical exercise. So recommendations and treatment plans have to be tailored to the individual client. In general, though, we need some zone 2 cardio, where we can still talk, but we know our heart rate is elevated, to get blood flow to our brains, to kind of flush out these toxins and bring in nutrients to help our cognitive function, and respond to cognitive rehab. So we know we need to build this in. It's just a matter of tailoring it, making sure it's safe, monitored, and building up our endurance to that, or our tolerance to exercise. Oh, am I getting enough sleep? So sleep is vital for our cognitive functioning. Some of our clients with PCC aren't getting consolidated sleep due to just this exhaustion and napping in the day, and then not having enough activity happening, that you don't have enough sleep drive built up. Also, just difficulty producing melatonin, because maybe we're not getting outside in the daylight to produce serotonin. As well as pain, respiratory symptoms, and other symptoms can really impact our sleep. Lack of sleep can contribute to our increase in our difficulties with our cognitive functioning. And if our clients are experiencing insomnia, we need to help them sleep. Looking at their schedule and routines and overall sleep hygiene is the first step. In typical insomnia, we would look at restricting sleep. However, with our PCC clients where fatigue is such an issue, we need to be very careful in our sleep recommendations. And once again, we have to really tailor this to the individual, of kind of regulating, okay, well, maybe we decrease our naps a bit, and then we try to stay up and we work towards that consolidated sleep a bit. But once again, it has to be really tailored.
So our next recommendation from CAN-PCC is about cognitive rehabilitation. So the CAN-PCC Collaborative suggests cognitive rehabilitation in individuals with post-COVID-19 condition and cognitive impairment. So this was, again, a conditional recommendation based, again, on very low certainty in the evidence. This recommendation is based on an indirect population as well. The evidence that we had came from an indirect population. And so it will be reevaluated if studies become available in a post-COVID-19 condition population. We also recognize part of the reason that this is a conditional recommendation is actually access for cognitive rehab can be really tricky, right? Especially if you live in a rural or remote area like I do in the north. It can be really, really tricky to access. So we recognize that as well.
So cognitive rehab. So yeah, if we can access it, we want it, right? And so if we can refer our clients with brain fog to practitioners who treat executive dysfunction and have experience with PCC. So we're looking at occupational therapists, psychologists, and speech and language pathologists who have experience with post-concussion, cognitive rehab. They're all going to have that skill set. So I mentioned goal management training. That's an executive functioning treatment program that's been highly researched in cognitive rehab. It's clinically showing promise for helping our post-COVID clients. It's also just important to note, which Melissa already did, that access to healthcare professions can vary widely by geographical location, and insurance coverage may also vary. So I know it's a real issue that accessing cognitive rehab is a real issue. Virtual cognitive rehab may be an option where applicable. Sometimes, depending on practitioners, like licensing requirements and things like that, will depend whether you can access different practitioners from other provinces or other countries that might be able to do virtual rehab. It will just depend on their licensing and their licensing bodies, if they can provide that virtual service in another province or country. But for cognitive rehab, we're really setting goals and helping our clients break their tasks down into really small goals that they can gradually reach. We are problem solving through energy demands of tasks, and really first steps are cognitive hygiene. So we can go ahead to the next slide. So cognitive hygiene are just these basic principles to decrease our cognitive load and help our brain be more efficient. We want to do things the way that our brains are kind of set up. We want to kind of go with that. So we're really not meant to multitask. So we want to avoid that, kind of train ourselves for focused attention first, one task at a time. So this really includes checking email, social media, etc. Maybe if we're trying to do work, then we, on our computer, for example, that we take away all other distractions so that we're just doing this one activity. So daily meditation to decrease stress and improve focus. A lot of people will say, meditation doesn't work for me. I've tried that before. I just couldn't do it. But I just want to note that this is a skill, and it can be built, that any skill can be built, and we can get better at anything, even if we just get a teeny tiny bit better, if we practice and work through it and have people guide us through that. So often with clients, I just start with something like 2 minutes of focused breathing. We do guided body scans, visualizations, etc., and kind of find what works best for that client, what that resonates with them, where we're really just working on our focus and bringing it internal, as well as just decreasing our overall stress response levels. When we have a high stress response level, our cognitive functioning becomes low because we're in the survival mode versus like, I'm not going to problem solve through with this lion who's chasing me. I'm just going to run and get out of the way. So we utilize those things to kind of decrease that stress response, but also improve focus at the same time. As far as, the present-minded practice, I usually get people to pick one activity a day where we focus on the activity and use all of our senses to bring our focus in. So for example, if we're brushing our teeth, we're really going to feel the toothbrush in our mouth. We're going to taste the toothpaste, maybe the cold water or warm water, however you brush your teeth, but we're really focusing on all the senses of that activity. Once again, we're building focus. I talk to people about writing down distractors. so that we're not squirreling, going back and forth, jumping back and forth between tasks. Write them down so you don't forget, but stay focused on the one activity again. And schedule in our to-do list items. Yes, plan your day. So this is a planner that we created here at our clinic to help with pacing, goal setting, and managing your day. There's a lot of free ones online as well. It's just really about making a plan. We try to have consistent wake up times, activity times, and rest throughout the day. And it's really individualized where they are at with function. Teaching what rest can look like, which I spoke to in the last slide with the body scans, meditations, and present-minded activities, can be forms of rest. I like to sandwich triggers in with down-regulating activities so we don't have as much of a crash effect on the person, but really making a plan so that we're even scheduling in times to like check emails or things like that. So we're really trying to do one activity at a time.
So we have a couple of other CAN-PCC recommendations that do relate to PCC and brain fog. One of them is that the CAN-PCC Collaborative suggests against the use of hyperbaric oxygen therapy in individuals with post-COVID-19 condition and cognitive impairment. This is, again, a conditional recommendation based on very low certainty in the evidence. Although there have been some reports of people with PCC experiencing some good effects from hyperbaric oxygen therapy, a part of the reason for this recommendation against is that it's very difficult to access and it's very expensive as a possible treatment. Okay. Another recommendation is that the CAN-PCC Collaborative suggests not using central nervous system stimulants for individuals with post-COVID-19 condition and brain fog with or without post-exertional malaise. Again, this is a conditional recommendation based on very low certainty in the evidence. So as you probably know, although there is more and more research coming out on post-COVID condition or people with it, as we're creating these guidelines, we have to use the available evidence and the studies that have already been published. So we often have to use studies that are on an indirect population, people who have something maybe similar, but it's not post-COVID condition. And so it's also important to remember for like this particular recommendation, if, for example, someone is already using a CNS stimulant for another reason, to treat ADHD or something like that, then this wouldn't apply. So this is looking at specifically using stimulants to help with brain fog in PCC. All right. I think that might be the end of our presentation. We were fast.
Yeah, and I feel like I was just thinking, I feel like we didn't really put in a wrap-up slide for it. But I think that I look forward to everybody's questions and some discussion at the end here. But I think really looking at, when we're looking at does cognitive rehab work? Does it not? What can I do about my brain fog? These types of things. Definitely, if you can access providers, that's wonderful. Starting to build in cognitive hygiene in your day, things like that. And just knowing that other people are experiencing brain fog, it's really common in PCC patients as well as other diagnoses. So it's a common thing, and it's real, and we definitely are working through rehabbing people, and we're seeing success with that. So although sometimes maybe it's not like, oh, we have this cure for brain fog, but can we help make people's days easier, better, make things more achievable, things like that? That's really the goal that's really the goal in any rehab with people with chronic conditions, is how can we make things a little bit better, a little easier, and that's really the goal. So yeah.
And I might add one thing too, is just I also think about and it's something that we hopefully can address with people with brain fog as well is the impact it has on your self-identity. As someone who has always sort of prided myself in being intelligent and being able to manage all kinds of different tasks. I mean, when this happened, I was self-employed and I was juggling a variety of contracts and part-time employment, and it got to a point where I had to stop, and I had to pick one thing. So, and it impacts your income and all that. But even just when you can't even find the words to talk, I mean, you feel dumb. Like, honestly, sometimes I wondered if I was getting dementia at one point. I wasn't sure what was going on with my brain. So it's validating to get this information and to know that you're not alone. But I think also getting some support to say, this is really hard on me as a person to accept that I have these challenges. Yeah.
Yeah, and I think that's a good point, Melissa, because I think most of the clients I see in my practice are really high functioning individuals, and they were doing really high demanding jobs. So where people's self-identity are wrapped up in how their brain functions. Like, I'm a smart, intelligent, capable person. I've used this to be successful in my life, and now I don't know who I am, what I'm doing. I can't even find the words. And knowing that's not a reflection of your intelligence. Yeah.
Thank you both. We have some lovely questions in the chat as well. One of the big picture questions is, to what extent have these recommendations been integrated into the health system? So what are you seeing in your professional kind of context and practice about their integration?
I think, do we both work outside of the health system, Melissa? I know I work in the private practice sector, so I'm not seeing what is directly being integrated in the public healthcare system. So I don't have a great answer on that, but if someone else can, and hopefully this webinar maybe helps integrate some of these things as the education. But if you have anything to add, Melissa, or if anyone else does to that.
I'll just quickly add that we're rolling out these recommendations as part of CAN-PCC, and we know that this whole piece of knowledge mobilization, what we're doing today and trying to get this information out, is still hugely needed, and we have a lot of work to do. So I would say that I think all of us with PCC are still finding there's a lot of a lack of knowledge out there, but it's improving slowly, I think. Yeah.
And we have some additional questions in the chat, and we also have a hand up. So I'll have one more question from the chat, and then we'll go to the hand that's up as well. So one question was around, how do you distinguish between a nutritionist and a registered dietitian? And I believe there was just an earlier slide reference or mention of it. So.
Oh yeah. I guess you can ask for someone's credentials, and either way, a nutritionist or a registered dietitian, either profession can definitely help you. It's just dependent on what your comfort level is, and just research any practitioner before going to see them. And if you have private insurance, your insurance might only cover one or the other. Yeah. And within the health region, it's in our health region anyways, here would be registered dietitians that you could access. Not easily, but you can access them. And sometimes there's other practitioners working who are nutritionists and have different qualifications.
Thank you. Yeah, we'll go now to Kathy. Thank you.
Hi there. I'm Kathy Schofield Singh. I'm a nurse practitioner in Manitoba. However, I also got long COVID. I actually got it back before it became officially aware of it, but it destroyed 2 years of my life for sure, and then gradually took time back. I've been referred to, I deal with the brain fog. I deal with the post-exertional malaise. Fatigue is just ridiculous. And in my job, that is a really bad thing to have. The only practitioners who I have found that have really started to become aware about long COVID are ones who have patients that have long COVID. I've been sent to a lot of specialists, and they just go, they don't know anything about it. or they just poo-poo it, or like I've developed a regular heartbeat now that I never had before, and they just tell me, oh, lose weight, and that and even though I've actually lost 100 pounds, but still, but it's a really frustrating system for most patients who have long COVID. Most physicians have not, or nurse practitioners have not taken the time to really learn about it unless they are really affected by it themselves, unfortunately. Whereas here is, I'm in Shoal Lake, Manitoba, about an hour from Brandon, and that. So I do take care of clients with long COVID. So if you are in my area and you need a healthcare provider, I actually have room in my practice. So come on over.
Mhm.
Thanks.
Yeah, and
Thanks for sharing, Kathy.
thank you, Kathy. There is some echoing of that idea in the chat that it can be hard when there's either no primary care doctors in the area or in rural communities sometimes to find the spaces, but or the idea of even knowing which healthcare providers are going to believe that PCC is real. And I see that also in our Q&A, that there's some concern or an ideal of maybe of a list or just maybe that identification, kind of like the safe spaces icon I remember thinking about. It's like, you know, for PCC. I guess the question I had then coming back to our long list of questions is, how do patients, if they're in a virtual environment, are there any diagnostic, any diagnosis options for the executive dysfunction that work in a virtual environment that you find? Like if you have a virtual appointment, for example?
Yes, it's more difficult for sure, but if we can email out forms, and we can definitely do different assessments virtually. Now, depending on, if you have maybe a long-term disability provider is requiring the assessments, they might not take that assessment as valid if that's not how the assessment is intended to be validated. But if it's for your own like personal rehab journey, and it doesn't matter the standardized procedures, right? We're just looking to help people see where their difficulties are and help kind of bring about rehab programs, then we can definitely do different virtual options for assessment and treatment. Yeah.
Thank you. I'll just make a note that there's some chatter about different places that exist in different provinces, and we do notice that there are differences. I know the CAN-PCC nationally has been very aware that different provinces have different access in terms of which specific clinics are available or coverage and stuff like that. There was a question around kind of like coverage for like the cognitive, let me pull this back up, sorry. Just in terms of having coverage for cognitive rehab, and just kind of those patients who are not working, as mentioned, can be a challenge when you have it. So what have been some of the options there, or things that you've been able to notice or suggest or see colleagues doing with regards to patients when they have that challenge with coverage for cognitive rehab?
Yeah, so a lot of people are coming to us through long-term disability programs, where we put together maybe an assessment of someone, and then we put together a quote for a long-term disability. So if you were working prior and you do have long-term disability coverage, there's these pools of money for rehab with long-term disability, and you would be assigned a rehab coordinator, and definitely a lot of people are getting coverage that way. There's also, I mean, if you have benefits at all, there might be some coverage that way. Yeah, as far as through public health, like I don't think I'm in Regina is where I'm at, and please someone correct me if I'm wrong, because I could be wrong, but our OT outpatient services would be very well able to handle this type of rehab, but I don't believe they're seeing long COVID or post-COVID condition clients. At this time, I don't believe they are, but in some centers they probably are seen for cognitive rehab, but I don't believe in ours in Regina that they are.
Okay.
I can speak to what I know of here in the Yukon. We do have, there's public access to OT and physio, as well as home care. So home care could be an option. The challenge that we end up experiencing is that the criteria to be able to access these programs often are too stringent. They're too high. So the expectation is that you really just are not able to function at all. Whereas some people, with post-COVID condition and brain fog, are still functioning a certain amount, and that just might not meet the criteria, which is too bad. Like, I think there could be some room for, improvement and change in those sort of policies and criteria. But yeah.
Yeah, and I know that everyone's individual circumstances are different, and definitely, I also, we've had some clients, but I also know is that people are investing in their health more and more. So sometimes people will choose to pay out of pocket. And we really, just like everything I've said right from the start of individualized, tailored programming. So if we know we're working within a budget, right? If we're okay, so, so we can tailor that with homework, things like that. And maybe we're just checking in versus doing weekly therapy. And we really want to plan around what people can do and try to, meet people where they're at. And, we have put together programs where we've had, maybe our clinic has done maybe pro bono in the gym, but they're paying for OT, or where we just individualize things to try to help people out as best as we can.
We also had a question around when discussing to get exercise, and this kind of goes outside of brain fog into a bit of PEN. It's what are the limits to avoid PEN? So if you're trying to get more exercise to help with brain fog, how do you balance it when there's those multiple symptoms?
Yeah. Absolutely. Individualized and tailored. That's going to be my common thing that I keep saying, right? Is, if we start, what can you tolerate? Okay, you can tolerate 1 minute. Let's start there. You can tolerate at a heart rate of 75. Okay, let's get your heart rate up to 75. Let's start there and safely build. And what does safely build look like? I know is going to be the next question. Individualized and tailored. Yeah. Monitored.
Thank you. And I think one of the comments there was just around, again, there's some comments in the chat of the variations in support, and there's also comments in the chat around the idea, the difficulty sometimes if, again, no money or limited access around there. So we acknowledge that. And CAN-PCC has a group that's also working on some policymaker resources. So there are resources to send out to policymakers as well, and those will be available on the CAN-PCC website once they're finalized. Just one clarification from earlier, is the registered dietitian the same as a nutritionist? Just to final clarify. No, and I'm seeing head shakes on no. So thank you for clarifying that again. And then as we go into the other questions, just are there strategies that you've found particularly helpful? And I know you outlined several for individuals who are looking for cognitive rehab, so to help clients improve. So what, in your experience, what are the strategies for cognitive rehab that you found most helpful with clients to improve? And I know individualized care will come up in the answer, but maybe if you can provide maybe some examples. We have about 9 minutes right now. So
yeah, you bet. So first things first is that cognitive hygiene strategies of building focused attention. So before we can work on divided attention and multitasking and things like that, we have to build our capacity for focusing on one thing at a time and streamlining that. So where are we starting and what are your difficulties? So that's the assessment piece, right? What part are you having difficulties with? So then generally we start building focused attention through those present-minded techniques, things like that, picking activities that someone already likes. And let's see, well, right now, can you focus on that activity for 5 minutes? Well, let's see what happens if we try to stretch that to 7 minutes. So we're just building that capacity. And then as we build capacity, we just slowly make things harder and harder. So then, okay, well, maybe now we're going to do that activity with background noise in, and, you know, and then maybe, and make it more difficult that way. Or maybe we're going to do a little bit more difficult activity, like, you know, maybe we started with just a simple memory game or something just to focus our activity. And then we might build it to like, okay, let's play a game of sequence where we have to go back and forth. And note that like things like board games and like, I don't know, like Wordle and word games and things like that, they don't help your cognition in the fact of like carry over to all these other activities. But some of these cognitive activities we use just to build sustained attention. That's not going to fix, you know, if you do Wordle every day, it's not going to carry over to all these other things. You're just going to get better at Wordle every day. But when we look at building sustained attention, increasing that, and then we look at like, how can we replicate maybe what we did in the clinic or what we did for homework in our daily activity? So maybe in cooking, we start to look at our recipe and work on our working memory to see, can we remember 3 items off of this when we go and do our cooking task? And, you know, can we help our brain out a little bit? And maybe we're going to sort them. And maybe there's 1 teaspoon, the items that all have 1 teaspoon. We're going to try to remember those 3. And then we build that in, and then we make it more difficult. Or going to the grocery store, well, let's try to remember 3 items off our list that are in the produce section before checking, instead of getting there. What am I doing? What do I need? So we organize, we practice these strategies, and then we take them into our everyday life to build. So yes, individualized, tailored, you're right. What are your meaningful activities? What's difficult? You know, if reading's difficult and we find that the reason reading is difficult is maybe some of the scanning for your eyes, well, then maybe we're doing reading windows, you know, or we're blocking everything out, but just doing 1 word at a time or 1 line at a time. Maybe bigger print is easier, you know, for you to be able to read things like that. And then, yeah, start with like, maybe we're reading 1 paragraph, and then we're going to try to recall it. And then maybe we're reading a chapter and then going to try to recall it. And we just take where we're at and make things slowly a little bit more difficult to build that success.
Thank you. And then a related question, and then a follow-up question. So I'll go with the follow-up question, and it was about this assessment tools for virtual service. And one person was asking anonymously, would the test of everyday attention or the weekly calendar planning activity be doable through a virtual service?
I don't think you couldn't with the test of everyday attention. You could with the weekly calendar planning activity, you could. You know what, and I haven't looked into the research too much, but to read the study in entirety, but I did see a study, which actually I think is in our references, where they used just the trail making, the Iowa Trails test, and it's really a connect the dot test. So one is like 1, 2, 3, 4 up to 20, and then one is like 1A, 2B, 3C, 4D, all the way up. And those you'd be able to do quite easily virtually, and you could definitely tease out some things. It would be harder to like, and you can definitely do working memory tests, just of like really simple, how many string of items can you remember? And those types of things you can do really easily virtually. And just note that the goal management training program can be completely virtual. It's set up that way. So any practitioner that does do the goal management training program, and was developed out of Baycrest, and can be completely provided virtually. It's all the tools are set up. So.
And I'll just show those references again, and then I'll go through the housekeeping slides, the final ones, and then we will turn if there's any further questions. And I believe there's one question remaining. So thank you again for your questions. These are resources available for patients, including my guide, as well as there's going to be interactive infographics and online resource sheets, and then the free webinars through CAN-PCC as well as through USask. There are resources for healthcare practitioners, including the webinars, the CPD course, and an EBM Connect training program. And there are also videos if you would like to understand more about the guidelines on the CAN-PCC website. There is a survey, and you'll see the link in the chat, as well as you're welcome to scan the QR code. And we do appreciate completing the survey and providing feedback not only to our webinar series, but also to our speakers. We're going to stay up to date. There's a CAN-PCC newsletter, and you also can visit the CAN-PCC website. And there are also additional webinar series, both through CAN-PCC as well as the remaining ones through USask. And we'll return now to the questions. And there's one question for any guidance on people returning to work or staying in work.
Yeah, I mean, I don't know if you guys have a webinar on that, but that could be a whole webinar for sure. I'm returning to work. It's really slowly, slower than most disability programs would be comfortable with, but avoiding crashes and if you're doing things to stay at work, like you're working from home and you're laying down while working or things like that, and you're not able to maintain your basic needs, then you might need to be going off work for a little bit to kind of make sure your self-care is happening first and foremost, and then add the work back in slowly and carefully.
And CAN-PCC's teams are still working on the recommendations. I believe there's more additional ones coming out at the beginning of February and then the beginning of March. If you also have a chance to provide public comment on any of the recommendations that are coming out, if you go to the CAN-PCC website, and there's information about their approach. So I want to say a tremendous thank you to our speakers today, both Melinda and Lindsay, for lending their expertise and their experience. And thank you everyone here for your questions and your attention in attending our webinar today. Have a lovely day. Thank you.